Hello, Rehab Counseling 650 class. And going over the Rogerian aspects of counseling, I was wondering how those principles might be incorporated with newer, more modern cognitive short-term therapy concepts. So I thought I'd ask my favorite Rogerian counselor to explain to this, Dr. Betty Hannawalt, my mother. Thank you very much. If you could just start with a brief educational and vocational background and then go into your practice now with, I believe it's the troops, isn't it?
Yes, it is. I have, my undergraduate degree is in biology and psychology. I then have a master's in criminal justice, and I have a master's of social work. I also have a doctorate in a PhD in clinical psychologist. I'm actually licensed under my social work, so I'm an LCSW, and that is the license under which I practice. I have used, well, perhaps let me start with who Carl Rogers was. Carl Rogers was an American, and he was one of the first to promote a self-centered style of therapy. The theory on which he based his therapy was that he felt that every person has it within themselves to resolve their problems. They know themselves better, they know their hurts, they know their pains. And he felt that if a proper surrounding or environment was surrounded this client, that this client then could really resolve his own problems. There are three primary characteristics of Rogerian therapy. One is being empathetic. One is also providing by the counselor a non-judgmental, honest sincerity with the client. And the third has to do with the therapist, and that's being congruent, being a person that is genuine. I sometimes have called this being in sync with yourself, knowing yourself and living what you know is right and true and moral for yourself. So if these three things can be surrounding the therapy room, I feel that the client, patient, can actually come to find that which is his problem or to help resolve his problem. I think that I, for one, incorporate Rogerian with other aspects of therapy. Rogerian therapy does not work as well with disorders such as schizophrenia, even depression, anything that is, the etiology is of a biological nature. However, because I think in many of these therapeutic settings, you need to be directive. Rogerian is a non-directive therapy. We do not presume to tell him what is wrong with him or her. In your particular study, I believe, you would not be able to use this alone because you have an expertise that is important for the client to know, and you could not do that or provide that in a completely non-directive setting. So I think you have to maybe set a empathetic setting, a setting that you are non-judgmental, a setting where you are totally congruent with yourself, and then at the time that you need to provide your expertise in this particular realm, you can do that with a little more acceptance of the patient. Some of the tools that I think need to be used in this particular setting is that of of, of listening. I think listening and communication is an important aspect to all communication, but to provide an active and reflective listening, be able to help reflect back to the client what the client is saying. Part of Rogerian, in a sense, is being a mirror to the client, having the client see himself almost through you. Genuineness, I think we have to be careful not to actually be too self-disclosing. Too much of that, too soon, can actually be detrimental to the therapy setting. I think in this particular case, less is better than more. And I think if we do use self-disclosure, we need to make certain that it's relevant. We need to make certain that the end result of our self-disclosure was a positive one. Our body language, I think, is very important. I often feel when I first meet a client, body language is so important, that we see that they see that we are interested in them, we're listening to them, we're attentive to them. And I do feel that that's important the first time. Perhaps after we get to know a client, we can be a little more relaxed in our body language. We might cross our legs and maybe cross our arms even, which in a first setting, a time that we are just getting to know the person, those things might seem to be defensive on our part. But we need to be open, we need to be honest, we need to look towards them. Our tone of voice needs to be such that it's a kind voice, an accepting and non-judgmental voice. We need to use open-ended sentences rather than sentences that would respond or be closed, such as that which would respond, the answer would be only yes or no. And often we need to paraphrase what they are saying to us to help reflect back to them what they have just said, to give them a little more indication to their problem that they are searching for.
Can you go over a little now with the work you're actually doing and the type of therapy you're doing there and how that integrates with the Rogerian or Carl Rogers theories?
I am actually a family advocacy counselor for the Navy. In approximately the late 70s, the Navy began working with domestic violence in the Navy, and in fact all of the military branches now have such a program. And in fact, back in the early 80s, when I lived in the Philippines, I was the director of this program. So when I found that this was the only available therapy, counseling job that was available, I really was kind of excited because I could see how far this program had come, how it had changed, how it improved. So I do individual counseling, and then a big part of my work is doing domestic violence groups, primarily with men. My underlying philosophy for this group is that there's often so much shame associated with violence that many of the men come to this group feeling very embarrassed, feeling very ashamed, feeling without much sense of self-esteem. My underlying goal for this group is to have these men learn new skills, new tools in interpersonal relationships, and have them not feel the shame that they feel when they first walk in there. And I think that that also can be acquired by my non-judgmental reaction to them. Of course, we know that domestic violence is bad, but they know it too. So they don't need to be told that, but they need to learn that they can learn new ways, new behaviors, and not be involved in that type of a interaction again. So although a lot of that particular group is cognitive in that we teach many skills, many new ways to handle interpersonal problems, rather than the way that maybe many learned as a child and in the frustrations of life that came out with them. So I use the empathy and the non-judgmental and the being congruent and genuine along with cognitive therapy. My individual counseling with these young men and women, by the way, has to do primarily with not just domestic violence, but in just various clinical natures, clinical reasons that people seek help in their lives.
Okay, very good. Well, thank you very much for meeting with us. I'm going to distribute this amongst the class, and I hope they enjoy it too. Thank you to my favorite Rogers therapist.
And to my son.